I am Devendra Desai. I am a gastroenterologist at PD Hinduja Hospital, Mumbai. My interest is inflammatory bowel disease.
Hi, I'm Dr. Alpa Dherai. I'm a biochemist at PD Hinduja Hospital, and the interest is basically in the therapeutic drug monitoring of for inflammatory bowel disease.
One of the first patients that I remember was a young girl, and she had severe ulcerative colitis, and we had given her infliximab. But at the end of induction, actually, she was still symptomatic. At that point in time, we actually put her on iDose dosing, and it took a while because she responded initially, then she had infection, then he had some furunculosis and all. So by the end of about a year or so, she was very well, and that was sort of lifeline for this patient.
Date which we get, it actually helps because the usual dosing of every 8 weekly doesn't work with us because our patients, most of the times we start biologics only in the very advanced stages because of the cost implications. So the 0 to 6 and then 8 weekly is usually a no-no for us. So when we did a TDMs, we of course would get all of them low. But then when is the right time? Because certain times if you give it at 4 weeks, you may be giving it too early. So if you're getting that trough level, which we can be predicted by the iDose, has really helped us to avoid antibody formation, because without that, I think most of our patients would have developed antibodies if we would have continued with 8 weekly. Just putting it 4 weekly randomly or 6 weekly, again, cost implications are too many for a country like us where patients are paying from their pockets. So this has also really helped us to manage them, not to develop antibodies, and treat them in a most cost-effective manner. So that has been a very win-win situation for our patients.
Just to mention how common is low infliximab level in our population. So the department where Alpa works, this is the biochemistry, and they do the infliximab level. So we have data on 900 samples from all over India, and 41% of our patient had low drug level at the end of induction. So this is important to realize that in these patients, iDose would be useful. And we do empirically try to adjust the drug level, but that is much less after we have access to iDose. I think it is a fantastic concept. It shows a ray of hope for patients who have active disease in spite of biologics.
It's very satisfying, trust me. With the way we used to see the patients and not able to do it repeatedly, we were doing the dosing. Of course, we're doing TDMs. So repeatedly doing the dosing, empirically, so will change from 8 to 6 weeks, 7 weeks, still not getting the targets, and then trial and errors. Now here with the target, in fact, sometimes when I'm estimating the level, I tell my technicians, this is what the level is going to be. And sure enough, it's 0.5 plus or minus. So that's where it has been very successful. So now
I have tarot card to predict the level, but I can't actually.
No, but I can. I had the iDose, so I can predict it.